set. So panelists, your microphone's on the whole time. So be careful what you whisper to each other. So good morning, everybody. Welcome to the TeleHealth Telemedicine panel. So my name is Mike Schumer. I am chairman of Medical Life Holdings, a portfolio of value-based emergency medicine companies. And we have three fantastic panelists to kind of share their experiences and wisdom with us about how they've been dealing with changes in healthcare, specifically related to telehealth and telemedicine. So before we introduce our panelists, just to make sure we're all talking in the same direction, a lot of people use telehealth and telemedicine interchangeably. We like to think about telemedicine as kind of a provider-patient encounter using digital facilitation. And telehealth, we think about more broadly as things that might even include providers working collaboratively with digital facilitation. And with that, we're going to focus our discussion today, and again, them sharing their wisdom and experiences with us on telemedicine, kind of the provider-patient encounter. So with that, I'm going to ask each of our panelists to do a very brief introduction of themselves, and then we're going to go right into sharing wisdom. We have a very short period of time, so I'm going to try to be the timekeeper for us today. If you do have a question as you're jumping out of your seat, jump out of your seat, and I'll call you, and we'll see if we can get that answered. Afterwards, our panelists will be here. You can walk up to them individually as well, too. So with that, Dr. Dodaro, why don't you introduce yourself?
All right, you said this is on. Sounds like it is. Good morning, I'm Dr. Dodaro. I am the Chief Medical Officer of Crucialist Emergency Physicians. We're a virtual first 24/7 emergency medicine practice that's augment and wraparound extension of primary care practices. We manage about 80,000 lives in 22 states.
Good morning, everybody. I'm Alex Prestopiccio, Chief Medical Officer for Millennium Physician Group, primarily a group of primary care with multi-specialty as well. In the state of Florida, 19 counties, we manage about 475,000 lives in the state. And we've been in the ACO for the last 12 years in savings most of the time.
Very impressive. My name is Louis Morgan here. For the past decade, I've been founder and investor of about 8 ACOs that have saved Medicare $800 million and have paid, Medicare has paid us about $400 million in performance payments. I'm also a founder and CEO of Blue Sky Analytics, a data analytics company that serves leading ACOs. Currently, I'm CEO and founder and partner of Citrus ACO and Physicians ACO in Central Florida here. And we're number 5 and number 6 in the country in savings rate. Last year, Citrus ACO was number 1 in savings rate in the country. So basically, we're a niche little boutique ACOs and do work really hard for our success. Thank you. Thank you, Mike.
Okay, thank you, three esteemed panelists. Let's jump right into it. So, Dr. Alex, we're going to have you start off because I sensed your passion when we were talking before the panel began. Everybody knows that CMS casts a big shadow here, including they changed their position favorably as little as 48 hours ago. So maybe you could talk broadly about how you've taken advantage of the opportunity to provide more telemedicine services to your members and all of your learnings along the way.
Sure. In terms of what has happened and how telemedicine has taken off, right? So we all probably have experienced in our organizations increased utilization of the telehealth aspect of this. This is certainly helped by the fact that they had 1135 waiver under the health services. And so that remains in effect for as long as the public health emergency remains active. And so that the 1135 waiver is a multitude of waivers, and telemedicine is one of those waivers. What that means, we're suspended. And what Mike was referring to is what just happened as of November 1st. CMS extended the duration of this protection for all of us. So this was set to expire in 60 days after the PHE was waived or ended. as December 31st of 2023. So whatever you are doing, whatever things that you are, trying to accomplish, it will have the input. So that's the information part, in general.
Perfect. And Dr. Alex will hand out his card for his attorney services on the side as well too. Dr. Nick, maybe you can share with us kind of at a high level what you've learned, and at the end of the day, this is all about patient care, cost and quality, and how it's impacted your ability to provide efficient care as well.
So great. I think, I'm going to speak to a little bit from the practical side of, what we look at when we're taking care of patients day in and day out. We've learned a lot over the last couple of years. One is, habits are hard to change. I think a lot of the patient community, we're used to going to a place and seeing a physician face to face, and changing that to comfort with virtual interaction or telephone interaction or video interaction was prompted by COVID. I mean, COVID changed everybody's interest in having a new habit. I think that was, while it's horrible we had COVID, there's some real habit changes that occurred probably for the better. I mean, we used to get on planes, sales meetings were always about getting on planes, flying to Chicago, having a meeting for an hour, flying home and spending 2 days doing it. Now suddenly we're all on camera or TV doing it in an hour and having a lot more efficient outcomes. And some of us have not gone back to traveling for sales meetings. Similarly for patients, I think it really changed to virtual has become an option. And the other thing we learned is virtual doesn't need to be complicated. We started out trying to come up with all these tele-video and synchronous visits and all that sort of stuff, and I'll tell you, it's like anything else, just get started somewhere, call them on the phone, start with the phone. So a lot of folks really either can't manage the technology, or when they're sick, they don't want to manage technology. But if you at least call them and start the conversation, the phone call alone solves a lot of things. And so the whole world, the payer world, and the billing and the coding people, everybody just got comfortable with talking on the phone, no patient documenting that, and somebody saying, hey, there's value that was paid for it. I think that's we've learned a lot, that if you can just take care of your patients and use whatever tools you have, you get a lot done. I think that's been a big change for us. I think it's reconfigured our thinking on, let's get in their lives and help them out. And it really doesn't matter how we do it.
And perhaps building on that, certainly what has happened to us, at least in our experience in that aspect, has been just in numbers, right? We probably in the pre-COVID achieved maybe 2,000 visits through telehealth, and now fast forward, 2020 and up until now, in 260,000 telehealth visits that we'll be able to accomplish. So at the end of the day, for this audience, what is important? Access. Access is the most important aspect of what we manage, right? The other important thing is how do we meet the expectations of the patients? There's a lot of thinking about, okay, they are elderly patients, at least in our case. My youngest patient, I do pediatrics, is 80 years old and above. And so the idea is, how do we get that patient comfort? And the reality is, we were surprised in a way, because all of them did FaceTime with their family. They were actually having that ability and that understanding. So what our challenge was to how do we do that compliantly? So we created, in a term of a month, we went through 9 iterations of including that workflow into what we do. For our end, and this is maybe the part that we need to solve for, is how do we get the documentation of that visit? Because it's so good. It's about access, we got it, they know how to do it now, they're not afraid. How do we integrate it in our workflow? So our biggest challenge at the beginning, and our biggest win, if you will, was getting the process of getting into an app, the app going into the web eventually being seamless. So the patient will get, in our case, an invitation, they click on it, they don't need to do any technology. They just click. On our end, what do? Is actually going into IEM. I think that's important. That's not, that level of complexity, certainly to your point, is just get started. The issue is use that technology, because the things will continue to happen.
Thank you, Dr. Ellis. I'd just like to comment that, as an ACO, we're here to lead our physicians into value-based care, and we show all types of different directives to do that. But we always we in RCOs take a view of helping physicians in a lot of different ways that help them, help their practice, help their patients, help their staff. And on the onset of COVID, I'll just never forget, it was March 10th, 2010. All of a sudden, our offices closed down. There were no patients. Our PCPs and specialists were flipping out. They were freaking out. It's like, oh my God, what do I do? My world just ended. I have no patients. I have no business. How am I going to pay the bills? Well, right away, within, I would say, by the 13th of March, we sent out, with the help of PDACO and some of the big boys around here, the protocols and procedures on how to set up telemedicine in your practice. And it had the ABCs of what systems to use, how to coordinate it, how to bill for it, how to contact your patients, how to do all these things. And the physicians, they just ate it up. They immediately put together telemedicine programs in their practice. They networked with key specialists that they needed also, and they continued to practice medicine. They continued to be able to bill and collect. They continued to help the healthcare of the population of patients that they were overseeing. And so I just think that that's like an added benefit of what ACOs are and what they can do for the physicians that are, and the patients that are involved with this. Just want to get from.
That's great. So I think what I'm hearing is that the first step of the journey might be the most important part, because there's so much to learn, and we don't like to talk about failings in medicine, but there's going to be a lot of process learning opportunities along the way. But as a quick show of hands, how many people in the room are either in organizations or working with organizations that are leveraging telemedicine today? How many feel they are 50% along the way of the journey of making it completely efficient? There's an opportunity for you experts right there. So perhaps maybe we'll go to the next question to Dr. Nick. What, along the way, all of the opportunities for learning and making sure this is a more efficient process for providers and for the patients, what have been some of the biggest learnings along the way?
I think some of the biggest learnings for us, probably similar to some of my first answer is, so we're in a space where, again, we're an emergency medicine practice, virtual practice, 24 hours a day. We augment a primary care practice. We collaborate with primary care practice. So, a lot of primary care practices have folks, they get anxious, they get nervous, they have a problem Saturday night or Monday morning or 2 o'clock in the morning, and they wander to a hospital for a solution. Our job is to interrupt that flow to the hospital, give them a better solution. And if we get in their lives, they start to find that talking to us is a better solution than wandering to a hospital at 3 o'clock in the morning or Saturday afternoon. And one of the learnings I think one of the things we learned real quick, and I think this is related to telemedicine and the change in healthcare, is that they're just looking for some guidance and some answers. They don't necessarily want to go to the hospital, so to speak. They want to talk to someone who's credible. They want to talk to somebody who knows them well enough to answer a question. Anybody who's got a clinical license of any sort, nurses and doctors and nurse practitioners, your neighbors and friends and colleagues, and your kids, mom from school will call you on Saturday afternoon and say, hey, this thing happened, what do I do? They're asking for guidance. They're trying to relieve their anxiety, and patients want the same thing. If you provide that same thing to them, they take advantage of it. And if you do it reliably and easily, again, that's where the telemedicine part comes in. They start to find that you're a better solution. So we learned real quick that if you just give them access to credible people around the clock, they'll start taking advantage of that, and they'll stop taking advantage of the lesser applicable. Hospitals don't do anything wrong, but they're not always the right solution for everything, right? I mean, the primary care office is the right solution sometimes, and the board-certified ER doctor at 3 o'clock in the morning can talk to as a solution sometimes, and sometimes a hospital solution. But they start to figure out where the right solution is because they want to have convenient, effective care. And if you provide that, again, they start to change what they do, which changes their outcomes, changes their satisfaction with engagement with their team and their physicians, and then changes your physician's level of satisfaction because they're taking care of patients in a way it's rewarding and appropriate. So I think we learned a lot about that. It's been a fun journey to interact with patient populations in a different way.
Certainly, that has been the experience, and I couldn't thank you enough for other specialties that are crucial to what we do, right? At the end of the day, it's avoidance of hospitalizations that are needed, ER visits that are needed. That's what we're telling ourselves and our peers every single day. So the important aspect is how we leverage a technology that allows us to do that. A very important point when we talk about value-based is what can we do now because of this regulation temporarily suspending, and we hope that it will continue, is that you can do and close care gaps through telemedicine. Now, it's very important, and I'm sure because of the show of hands that you are in telemedicine using today, that you probably know the aspects of the majority of the care gaps are closed. You can close through the telehealth. And the importance of that is that there is a list that, again, just changed, and the final rule of care, and they put a list of 270 or so, activities that can be accomplished through telehealth. The other important thing that you referred to is, guess what? I'm a primary care, a practicing physician as well, an internist. And what is best that I will take care of my own patient? So it's not an unknown doctor. I know this person for maybe 15 years, 20 years or more, right? So it's me who's actually at that time providing that care. So there is value in providing the care by people who knows you. So, and this has, in our organization, we do not take care of outside, right? So in another settings. And the other aspect that we learn is the integration of behavioral health into this is tremendously important. And actually behavioral health is something that lends itself very well to telehealth.
Very good. Again, speaking from the ACO perspective, during COVID and using telemedicine, all of a sudden just took off. We never did it before, and all of a sudden we jumped in the pool, didn't even know how to swim, just started to survive. We were able to evolve and be able to do our basic patients, where the doctors had their system set up and their assistants calling the patient, coordinating everything and making sure the doctor had the information so that when they went live with the patient, it worked seamlessly and he had the background, etc. So that was fine with, our regular normal patients. But when we looked at our sickest of the sick, and I'm going to spend a lot more time on this a little later with the question, but that's where the problem really, came about of. They're not able to do telemedicine. They don't have a laptop or an iPad that they can go to when they're 90 years old and they live in rural Florida, when they're very frail and they're pre-palliative. They don't even have a smartphone and know how to use FaceTime. And so that was a real challenge to us. And they're also frightened. They don't want to go to the doctor's office. They don't want to go to the hospital. They don't want to go anywhere. They're afraid that they're going to die from this COVID virus. And that's what they're being told by all the media. Which, by the way, is true. They go to the hospital, they go to a nursing home, and see it. For a lot of people. So that was a challenge for us. And we actually started with having medical assistants going to the patients' homes that were really frail. Help with our outreach providers, some of our individual doctors using medical assistants to go in, to do a questionnaire, to set everything up, and I'll go into it more later, but then to do the telemedicine visit. That worked for a while, but quite honestly, it's still a major challenge. And I'm going to talk about what the future looks like in a minute, so I don't want to steal the thunder. But that was a real challenge during COVID, because it got to the point of where our elderly were so frightened, they wouldn't let the medical assistants in. However, we did find that they would let the doctors in. And so we have a great outreach program with physicians, and we had physicians seeing these patients more often, and we had a good number on it. And again, I'm going to get more in depth on that in a few minutes.
So I read a statistic that over 75% of telemedicine visits over the last 12 months were audio only. So I'm interested to know internally how your providers felt about that. Kind of looking at the licensing hierarchy, was the adoption rate for telemedicine different from nurses, extenders, and physicians? Maybe Alex, I see you shaking your head.
Certainly, that was an ability to increase it to the highest level of your abilities, at the practice level. So the APs and the physicians and the level of confidence. And that's what you were saying as well. It depends. One size does not fit all. So the comfort level has to come from the doctor because we know the patient in this particular case. So we're very lucky in that respect, right? So we know that a certain patient and even a complex patient can be managed when we know them. And then how that was taking across the lines, from IMA to the APs and so forth, yes, it was different. The adoption came with time as the other doctors started to see the success. And in no small way, the pandemic kind of has accelerated this tremendously because to what we were saying, 30-40% drop in the visits, and those are visits that you cannot do, right? But patients, they didn't stop having diabetes, they did not stop having CHF, and they were not going to hospital because of that. So that created all these chronic conditions, help us at the right level be able to treat those patients. And now they like it. They are addicted to the telemedicine to a point that we have to make sure that it's at the right time, at the right place. Because we are for telemedicine, don't get me wrong. But telemedicine, it has a place in the whole toolbox. And I would say a very important one, hopefully one that remains through time and pass these difficult times. But we also learn that we have to target the right population with the right things to achieve the better outcome.
I'll just add a little bit to that. I think we've also put a lot of thought into who's answering the phone, who's talking to the patient. We default to the physician very, very quickly. We have a very low threshold if someone talks to the physician, other than an administrative question. Do I have an appointment tomorrow, or what time do you open, or something like that. So very few things don't make the physician. But we have also found, I think we find it critical that when the phone rings, a human answers the phone. So the more you interrupt the flow of that relationship with a menu or a button or anything, even if the phone doesn't get answered in 30 seconds, you're done. Kind of what we're finding. So some of the metrics, it's like it's call center metrics on wait times and lost calls and all that sort of stuff become critical because once you're building that relationship and trying to change those habits, the phone has to get answered, the human has to be on the phone, and the physician has to be so readily available. It can't be that they'll call you back in 2 hours or whatever. It has to be hang on and they get the doctor on the phone. And I think that has been what we've learned that, because once you, like some of you guys said, these folks resist, sometimes they resist you getting in their lives. What's going on? Why are you calling me? More flyers, more whatever it is they're going to call the program. It's not a program, it's practice for your doctor team, but they'll think that way. Once you get them, though, you have to deliver it. So if you don't deliver, you lose them, and that's what we've done a lot.
Well, Greg, let's take a survey. How many people in here personally have used telemedicine over the past year? Wow. I'd have to say that's probably 90% or plus. Okay, how many people would prefer not to have to get dressed accordingly, get in the car, drive to the physician's office, go through check-in, go wait in the waiting room, go wait in the exam room? Again, people are coming in, wait for the doctor. How many people would prefer, not all the time, but a lot of time, to have a telemedicine visit rather than going into the office? Again, looking at 85% or so. That tells us what's going to happen to telemedicine. And as I'm going to show a little bit later, the financial side of it, for our sickest of the sick patients, it doesn't matter if it's reimbursed. It really doesn't. Because the savings that we see by having more frequent care to those patients through telemedicine is better quality care for the patients, number one. We're staying on top of what's going on. And number two, it's great for our ACO. And if it's great for our ACO, it's great for our physicians. So that's how it works.
That's great. So to the extent you have any experience now looking on the outside, as we break down, we'll call it healthcare consumers into very broad demographic buckets of boomers and Xers and millennials, are you seeing a difference in expectations and adoption rates? And I'd really like to hear a lot about the expectations, because I think they're using it for perhaps different reasons. Who's shaking their head the most?
So definitely. So the younger, the millennials and so forth, the expectations are completely different. It's like, I do not want to go because most likely they don't have many chronic conditions. I am very efficient. And also when you talk about direct to employers contracting, and so there's different circumstances in with telehealth, not only the age, but the environment that we're trying to cover and we're trying to accomplish is extremely important, right? Because let's face it, sometimes if it's a bronchitis or something like that, in many cases, we can resolve that. Now, when we go to the older population with many chronic problems, it's more about a social event. So for my older patients, it's like they were glad to see us and to establish a contact, because that may be the second or third contact for the day. So on another basis is, so different populations, and they definitely have different expectations.
We went to a lecture by Ritz Carlton. They do a customer service thing on healthcare, and they took a survey of how long people got impatient standing in line at the counter 10 years ago, and it was something like 13 minutes. And they did 13 minutes, they were going to lose the customer. And they redid the survey 2 years ago, and the new impatience timeline was 13 seconds. And so that's thanks to all the apps and all the things. And so you're asking about, what are we seeing? We see that back to what I was talking about before, is that this serves that impatience need where folks just don't want to wait for anything. Sure, they also don't want to drive to the doctor and get dressed and all that stuff, but even when they get there, they're just parking and waiting and checking. It solves all that. And I think that's part of what is driving some of this.
So it strikes me that the older members of your patient populations are putting an emphasis on the relationship, and the younger members could more happily be described as healthcare consumers, wanting a little bit more of an immediate turnaround. I think there's a great opportunity for those of us in this room that are providers or serve providers, is that my sense is the payers are behind us on this. They don't understand that stratification, and they're referring to everybody as being healthcare consumers. I think they're going to miss the importance of having a trusting relationship with our patients. So none of this happens unless we get paid in some form or another. Perhaps you could address some of the high-level economics associated with this, and I'd be very interested, and I think the group might be as well too. What did that look like? Was there a financial impact early that you made up for? I heard you say, Alex, you did 500,000 televisits. Yeah, that's very, very, very impressive. So I'd love to hear any comments you have about the finances associated with this.
And to the comment that was made earlier, so the investment that we have to put in this case as a large organization, it was not a small one. And we created, all these applications and to make it easier for everybody to have that access. So that being said, at the end of the day, a dollar spent smartly is going to pay off in the end, because on a value-based world, not a fee-for-service, as we just heard, is very different. An investment today that does not necessarily reflect on the P&L today, it will definitely pay out, because first of all, we're doing the right thing. The patient remains engaged and the doctor remains engaged, because the issue is that sensation that there's nothing I can do about it. So I think that irrespective of the investment, we did see, it's difficult to quantify today to say, okay, we did so many visits. On the simple side of things, obviously we can count, 99214s and 215s and so forth, that they were 30% reduction, and now we're back and better. So on a calculation of what was the budget, for that, budgeted versus done. So yes, that is easy. But I think I will say that it's like an iceberg. The real answer is below the water. So all the things that we were able to accomplish and avoid ER avoidance, medication compliance, adherence, all these things are paying off great in the end as we accomplish this.
Thank you. Good. A couple of years ago, I was in the National Association of ACOs, and I heard a little lecture from a lobbyist for telehealth, telemedicine, in one of the breakout rooms, and I had the opportunity of listening to her and then sitting down afterwards, and she was telling some very interesting stories about it. It's really worth looking into the state of Washington, where, outside of Seattle, when you look at the rest of the state, it is rural, and there's a decent population. And when you're a big healthcare system, you're trying to take care of all these people. And they use telemedicine very effectively, and they made, 8-figure investments into it that they weren't being reimbursed for, but they're overall managing the cost of their population. In this case, they were the Medicare system in that state, basically. If it would cost for too much, the patients weren't being taken care of. And the results were absolutely phenomenal. And then in speaking to her, I said, so it looks like it really works. Is the reimbursement going to catch up with it? This is way before COVID. And she goes, it's really a shame. I'm on the Hill. I'm talking to congressmen. I'm telling you, they don't want to move on this. And the reason why they don't, they're afraid that these are runaway costs, that Medicare can't afford this, that it's going to be full of fraud. They're not going to be able to control it. And this is an uphill battle, and telemedicine's not going to happen. Then, boom, COVID, boom, Zoom. All of a sudden, it has blown up. I tried to call her not too long ago, and she's working 2 phones, and she goes, everything about me is blowing up right now. This whole industry is just blowing up. It's unbelievable what's happening, and you're seeing it right in front of your eyes. So I'll talk a little more about that.
Okay, so I want to leave some time for questions. So I think we've heard that adoption rate and expectations are different across different cohorts of healthcare consumers. Same might be said about different levels of providers within the practice. Sounds like there was a lot of maybe pain and learning opportunities along the way. Sounds like there's, I love your iceberg analogy, Alex, there's probably long-term a very great benefit to our patients as we start to continue the migration or accelerate the migration to value as well. And I think the most important thing I heard was take the first step, both strategically for our ability to be able to serve patients over the course of the next 10 or 20 years and to get the learnings going. And then also in regards to it may be something that's a cost of doing business as the government and the payers start to put more demands on us in regards to relationships and such. So what I would ask is panelists, and I think Louis, you're going to close us out. I'd like to know, pull out your crystal ball and tell us where you think this is going over the next 5 years. And Alex and Nick, if you don't want to spike, that's okay, because I know Louis has some thoughtful words for us as well too.
Good. Before I answer that question, let me just say that it was a very difficult time for our industry in COVID. And as an ACO and helping physicians, we not only led them down the road in telemedicine, but we led them down the road and told them all about the relief grants that are available. And we showed them how to do the applications. We had webinars and seminars. We were helping people, 18 hours a day and receiving hundreds of thousands of dollars of grants. We helped them with PPP. We helped them along. We showed them if they did this, this, and this in an ACO, they could do well. And 2 ACOs, 1 ACO, the average physician made $750,000. Another ACO, the average physician made $550,000. I've had physicians say and their wives, if it wasn't for the ACO and what we did during this past year, I'm not sure we would have made it. And so we see this ACO as really kind of partnering with physicians. I know it's maybe difficult in a very large scale to do, but we're a very grassroots, a little niche boutique, so we can give special attention. So the question is take a glimpse into the crystal ball and see what telemedicine looks like in the future. We've heard from our expert panelists that certainly, there's going to continue this accelerated growth of the industry. There's no doubt about it. And I think it's going to play more and more of an important role. But again, instead of focusing on all of the population, this is an ACO conference, and that's what we do. And I'd like to focus just simply on our ACO population, our Medicare population. And very importantly, on the sickest of the sick of our Medicare population. I'm sure everybody in this room knows the old adage that 5% of our patients make up 50% of our expenses. So if I have a 10,000 patient ACO, 5%, 500 patients make up half of my expenses. Let's say it's $100 million. So 500 patients cost $50 million. about $1,000 a patient. So if anybody's looking to save money, that's a really great place to start. And that's what we focus on. And when we look at, these programs of reaching out to patients at home, that has been a primary objective of our ACO, is to have an outreach program to work with both outside providers as well as our internal providers in the ACO to help our patients at home. They need more help, particularly those that are pre-palliative. They have difficulty going to the physician. They're going to the emergency room a lot. They're going to the hospital. They're leaving home and going to the SNF and then coming back, and then they do it all over again. And it's a downhill battle from there. If you can see them on a frequent basis and take care of what their needs are, very similar to what I saw with Village MD and what they're doing with patients at home, it makes a big, big difference. So what do we see? I see that in 5 years. By the way, that's not a lot of time, but in the technology world, that's a lot of time. But there are hurdles like getting FDA approvals and getting reimbursement is an issue and stuff like that. That takes a little bit of time. But I see the world of chronic care management, CCM, and remote patient monitoring kind of come together. And I see in the device industry, where I initially had my roots, of having better user-friendly monitoring devices for weight, blood pressure, pulse rate, glucometer, oximeter, oximeter, ECG, Holter monitoring, in a way that a patient can be wearing a device that is very friendly and they'll be able to monitor the patient 24 hours a day. There are people that tell me, oh, we already have that. I've seen a lot of it. It's not really quite there yet as far as being user-friendly, and there's a lot of different things you have to do. I think there's tremendous strides that are being made in that particular area that are in development. Then there's the connecting that with telemedicine and being, as Dr. Alex said, at the right place at the right time. And I see that in that world of looking at our most frail patients, our sickest of the sick, of which right now we're visiting, not 5%, probably 2.5% at home. But at home, visits are not enough. We need to monitor them 24 hours a day, 7 days a week, 365 days a year. And we need artificial intelligence to kick in. So when you set up a patient on their parameters, that if they go beyond that, and if within predictive analytics, they can determine that there's going to be an episode, that there's an alert that comes out. And when that alert goes out, what happens is the television turns on. This is happening right now. A light goes on. Cameras activate. A provider comes onto the television. Sounds a little scary. But when you have a patient that has COPD and can't breathe and is full of anxiety and wants to call 911, they need help, and they need help right now. There's a lot of different things to do. So now we have the doctor on the phone, or I should say mid-level provider on the phone. And depending upon the situation with the patient, they triage the patient. Do they need to have a PCP get involved? They have PCP involved. Do we need a cardiologist specialist to get on the line? We have that available also. And so all of that can happen right in front of the patient to see what's going on with that patient, what their background is, with their vitals, etc., and what's going on to be able to make a decision. Do they need to go to the emergency room? Should we send an ambulance over right away? Is it on a weekend where they need to go to an urgent care center? Is it a situation where we can talk to them for a while, calm them down, and they can go to the primary care's office tomorrow morning? Or maybe send in?
That was a very not subtle time cue.
Oh, yeah. All right, sorry, I'm running away. Okay, I'm known to do that.
Good stuff.
Known to do that. Okay, what we're talking about right now is actually happening. There's a company in the West Palm Beach area called MedSign that raised a bunch of capital. They're doing tests with the VA. Everything that I'm talking about right now is actually being tested. And so when we look at a glimpse of what's going to happen in 5 years, 24-hour monitoring, telemedicine being used for referral patients to provide a better quality of care and to, help save our population. So reimbursement doesn't really matter. As an ACO, we'll spend that money to do that because we know it's worth it for our patients at very scale. Thank you.
That's great. So, Alex and Nick, do you have anything you want to add, or we want to go to questions?
I hope the future holds a little bit of standardization on platforms like televideo platforms, standardization on EMR connectivity. That's the stuff I have a lot of trouble with. We can't get the information back and forth. I really hope in the near future that we solve a lot of that so that everybody's phone, no matter what platform you're on, can talk to each other with a video or an audio call and not have any complications on compatibility and EMR connectivity. I think the future's going to really fix all of that.
I say in jest, was that a pitch for blockchain? So, all right, so we're at 11 o'clock, which is when we're supposed to end, but we did start a little bit late. Does anybody have any questions for our esteemed panelists? We'll start in the very back.
So I got a tangential question for you guys, but really important to the ACO community. I run an ACO in New Jersey that we have 60% leakage. We probably could get it down to 30 because there's some things our main hospital doesn't do, but 60% leakage. My question to you is, have you found telehealth to be useful in getting patients to follow directions and suggestions and come to you with issues rather than self-referring to the big gorilla orthopedic group or something else?
So to summarize, for ACOs that may have a few of their patients that like to self-direct themselves, is telemedicine a tool to help with leakage?
Certainly, yes. The answer is yes. And because the other things that we learned, another learning curve that came along the telehealth, is all the things that we wrap around. So again, remember I said telehealth is one tool in the toolbox. The other, so chronic care management, 24/7, direct contacting. Let's remember that there's patient-initiated, communication. All of these things. So one of that, the point that was made earlier, is not going to work. So, but it's not working when I'm in front of the patient. So why are we thinking that when we are in front of the patient, right, in a visit, in the office, one-to-one, and I tell them, please take your Lipitor, take your lipid medication, and the patient does adherence and things like that. Those will happen when you wrap around each taking. Then you have a pharmacy. Then you have all these other structures set around that will happen.
One thing we found is that helps only if the engagement with the patients. So you know the group, right? You do the 5%, so it's 5%. Those 5% have a very personal relationship with the practice. Until you do that, I don't think you ever change that, to your point. That engagement piece is critical, and that's almost a bigger lift than delivering the medical care.
So it's about it's a tool to help with a trusting relationship. Okay, a few more questions before we run out of time.
I had a question regarding your visits with patients. Y'all touched on it earlier. The two different models where you're seeing patients you currently take care of versus the ER model where you're seeing patients you haven't seen before. In the experience of the ER model, are you finding that to be really a difference? Some of our experience is that people really don't care. What's your take on how much they care about the provider they're seeing?
So we put a lot of effort into developing. So we take emergency medicine physicians for us, and we deprogram them from their hospital life. So that's number one. You let someone talk to people and behave like an ER, and I'm one of those guys, right? So I had to deprogram myself. I spent a lifetime of shedding my habits from an environment that's not necessarily optimal for patient care. You have to retrain these folks to communicate, develop rapport, and have a warm relationship with patients. So they care is the physician cares about them. They don't necessarily know that. So we have, for example, 40 physicians. Anyone any given Tuesday at 3 a.m. to answer the phone. You can't have the same person every day. Unlike Dr. Perez's model, you get the same your physician. We have to have a little bit of rotation. So if you have to empower these physicians to learn how to have warm and capable relationships with patients. That's key number one. then the patients will work with you. And then they learn that you're a team, and you share the call and that sort of stuff. So it kind of goes back to the engagement, the rapport, the communication is really primary. The technical aspects of knowing emergency medicine really comes down secondary after that. But if they like you and then you do good medicine, then they start to trust you. Yes, that's a quick answer because we're out of time, but I can talk about that in 3 hours.
So is it true, did I hear you correct, Dr. Darrow, when you said that you are decreasing downstream inpatient stays about 60%?
That's amazing. That's exactly what I said. Yes.
Making sure I have my memory was served. Okay, next question. All right, let's do, I think we had a couple here. Or big it. And then one.
You had mentioned that you just extended the time till December 31st, 2020. Can you touch on it because it's CPT codes and also interstate licensing?
Sure. So that's a very loaded question. So, be prepared. I'm not a lawyer, as he disclosed it the first day, right? So with all the little written fine print, let's go. So number one, on the state of Florida, because of the 2 emergency authorizations were canceled, right? So now we can do in most states, so we can do it outside the state of Florida, but coming into the state of Florida, telemedicine has restrictions. As you know, you don't need to have a license. You need to be registered with the Department of Health. That's number one. Number two, in terms of how this is gonna play in terms of the deadline. So initially, how this was written, the HHS determined that it was going to be for 30 days because they didn't know what, and they declared PHE. That had a 60-day expiration. That's all. Now they say, well, it's going to expire either on December 31st, 2021, or at the end of the PHE. This was just changed because that was an uncertain time, and it was the later of those two. And what just changed on November 1st, as regulation published by CMS, says, no worries. I don't know. So forgive me, but I don't know. Technically, this has been extended to 23 because it was in the law to be for 2 years after.
Great. That's our last question.
Gentlemen, thank you. This has been really informative. My question is, how much do you believe the transition, the shift to telehealth will come from just smart clinical and financial sense and practice, or how much do you think is going to be external influence, let's say, from the federal government?
So if I'm hearing you correctly, on the adoption curve, how much external motivation do providers need versus internal? That's a Harvard Business School framed question.
All right. So certainly this is going to be, so on the one hand, it will depend where you are in position. So if you're an ACO, to the points that were made earlier by all of us, is you cannot concentrate on the cost just now. Now, it's very different if you are a small group of physicians that now have to foot the bill and you have to set all the systems in place to do that. Now, you probably are not going to deploy a very large system and very sophisticated, integrated with the hearing market. So, bottom line is going to be, I think, it's going to be very diverse according to where you are. Now, very, very helpful that at the moment there is parity between the visit. So we are getting paid by CMS the same amount, whether we do it in person, whether we do it by telehealth, right? So that will expire when the PHE expires, because that's part of the waiver in 35. But again, all those things, everything needs a lobbyist, right? So how this is going to transpire, how this is going to be supported, it's a learning curve, and the idea is, does the federal government, do the payers see value in this? I think they do, and I think they're behind it. I think this will survive COVID.
Great. So to our fantastic panelists, we're going to close out because the hook is here. Louis, who is an ACO maven, Nick, who's an emergency medicine specialist, and Alex, who's a physician leader and not an attorney. Everybody put your hands together for